Submalar cheek hollows. The posterior jugal fold occurs due to atrophy in the fat compartments of the masseter muscle. On the vertical plane, this fold extends between the zygomatic arch and malar bone at the top, and the mandibular arch at the bottom, and does not correspond to any bony structure. On a horizontal plane, the depression extends from the middle of the cheek, sometimes even at the platysmal cutaneous insertion in the preauricular region, a quasi-fixed structure given the presence of fascia and ligaments. The fat loss in the corresponding fat compartments is associated, to a lesser extent, with the activity of the peribuccal and masticator muscle. A specific anatomical entity is involved in the jugal anatomy. Bichat's fat pad, essentially developed in children and found in the superficial buccinator muscles and deep cheek masseter muscles. The loss of volume in Bichat's fat pad contributes to the sinking of the cheek. The main anatomical precautions for the jugal injection involves the buccal branches of the facial nerve, which extends to the deep anterior limit of the parotid gland, to the superficial peribuccal region and the facial pedicle, which passes in front of Bichat's fat pad. Bordered by the zygomatic arch of the cheekbone at the top and the mandibular line at the bottom, filling the posterior part of the cheek or masseterian fold may be done using many different techniques based on the indication, facial physiognomy, and the patient's wishes. For the most common case, we will choose a netting or grid technique with 2 crossed fans, allowing to fill and smooth out the thinned jugal zone. The first insertion point at the bottom rear meets the mandibular angle and corresponds to this same mandibular point when correcting the facial oval. The lateral fan of the angle rises upward to the lower edge of the zygomatic arch and cheekbone and forward to the anterior limit of the jugal fold. If the depression needs additional fills and lifts, a second fan can be created with a high rear insertion point around the lower edge of the zygomatic arch. This second fan is in the direction of the anterior and lower limits of the jugal fold being treated. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, resulting in a netting or grid technique if volume restoration of the posterior jugal fold requires it. The results obtained using the radiesse injection are as follows when restoring volume to the jugal fold.